Hello and welcome to yet another episode of Keep It Real with Dr. Pradeep Nisar. Today's episode is very special since it marks the 10th episode of my series, and I'm so thankful for all your support that you have shown me, and I hope this continues in near future too. And having said that, being the special episode, we have a special guest today with us. Today's guest is someone who represents the evolving face of modern anesthesia and pain medicine. So we have with us Dr. Kaushal Bhonsle, who is an anesthesiologist and interventional spine and pain physician. Sir has completed his MBBS from BVU Medical College, Biraj, followed by Diploma from Goa Medical College and his DNB Anesthesia from BARC College, Mumbai. After that, he pursued various fellowships like PainMedicine, Endoscopic Spine Procedures, Palliative Care and Clinical Rheumatology. So there's a lot to cover in this CV, so we will directly ask it to Sir himself. Today we will talk about anesthesia as in for a PG branch, then the career prospect and various challenges that the anesthesiologist face. So stick with us till the end and let's start. So I welcome you, sir, in today's episode. How are you doing, sir?
Are all good?
Yeah.
Thank you, Pradeep, for the nice and brief introduction.
Yes, sir. Yes, sir.
It's my pleasure to be on your show and in your podcast.
Thank you, sir. Thanks, sir. It's been a while. I really wanted to do anesthesia, and I'm really glad that I got someone who has been such a decorated personality in the field. Can you tell me about growing up, how the environment was, your schooling, and as such?
I'm Dr. Kaushal Bhonsle. I'm an anesthesiologist and interventional spine and pain physician, as you already described.
Yes.
I'm originally from Goa, born and brought up in a rural village of Kolwale, which is in North Goa, which is almost near the border of Maharashtra. I did my schooling there. I've been born, brought up, all schooling till my 10th from a school, St. Rita's High School, which is in Kolwale itself. And then I did my higher secondary from St. Xavier's Higher Secondary School, which is in Mapsa. Till 12th, I was an average student. I was never a topper in my life.
Okay.
But there was one thing which fascinated me, and that was science. I was always a hard worker and a very curious personality. I had interest in innovations. I had interest in scientific technology. I had interest in aerospace. So my interests used to grow up in the field of science. And I think that is what pulled me towards medicine later on. I used to ask a lot of questions. My teachers used to be all into that, why he's into asking. So you can imagine how it had been.
Yeah.
So I have always been this curious person, things to learn, and whatever if I find interesting, I'll go into extreme depth of it.
Any background of medical personalities like you, like your father or parents?
That's a good question.
Yeah.
I am a first generation doctor.
Oh, very nice.
Yeah. My father is a banker. He was working in the State Bank of India. And my mother was a government employee. So I have been raised by both working professionals, which gave me a lot of time to think and read. And I was always involved in a lot of books. So that has been how my childhood progressed.
Okay. So you've always been into academic sort of things, more interested in knowing things, in going in depth of them.
Absolutely.
Yeah.
I was more into that. Plus, I had few interest in sports here and there as a hobby. But more into books, more reading.
You have done a lot of things like your degrees and the various hospitals you have worked. So can you just give us a brief idea of how that timeline works?
When I started, it was a journey where a lot of information was not available. Internet was not there, or internet was just beginning stage.
Yeah.
So information was from word of mouth. I being from the rural village, there were very few educated people who had there and who came. So they were the guidance. And what my parents were of the idea that there are two fields. One is engineering, another is medicine. That too in engineering, I was not aware that there is something called IIT exists or about medical colleges or what other colleges. For us, it was only GMC or what other options are there.
Yeah.
So when I went to Xavier's for 11, 12, that's where I got real information. Information about medical colleges, information where what courses can be done, what entrance exams are possible and how you are supposed to prepare to it. So that's when I started preparing. First, this is before NEET. The NEET era was not there.
Yeah.
There was this common entrance test supposed to happen, but that was not in the pipeline yet. Till then, it was 12th mark list.
Yeah.
So on the percentage of the 12th, the ranking through the medical college was there. So then if you are not in the top 30 or 40, you are not supposed to get in Goa.
Yeah.
So the
I
other
remember that.
options were the neighboring states.
Mm.
So then you have to prepare your medical entrances or whatever in that way.
Yeah.
Because if you are not in the top 40, you are lost. And then the other option is engineering. That also had only few seats. It was only GEC.
GC, yeah.
PCC was just gonna start, and all colleges were just about to start in Goa especially. So then I started preparing in all India perspective. Some teachers, my seniors, they guided me in the college. So Xavier's was a very important learning step to me. After that, with the thorough preparation, after my 12th, I took a drop to prepare for a medical entrance. I said I was an average student. I was never a topper. I got into Goa, but I was not getting into MBBS. First choice was MBBS. Second, engineering BS was later on, but first choice was MBBS. So I decided to take a drop. I prepared all India, and same time I repeated 12th another year to increase the percentage. So it was a double. Anyway, I'm taking a drop, and you have an option to answer 12th again.
You can answer like that.
Yeah, you can answer 12th again.
But the headache of studying.
Yeah, lot of people are not aware that you can do that. So that is the advantage. And then it improves your percentage, and it will help you in the longer run.
Yeah. But it counts as what attempts? Like second attempt?
See,
like
attempts and all that is considered afterwards. And attempts count when you have not passed in the first one.
Okay.
So if you have cleared in your first attempt and you are just attempting, it is again a first attempt.
Okay. This I didn't know. This is I'm hearing first time.
Yeah. So that is it. So then I prepared for All India. And after All India, I came to know that there are separate CET exams which are for Maharashtra state, then there is for Karnataka state, then there is one association of semi-private colleges. So that's what I started preparing to. And then I started answering exam. I was traveling from Belgaum to Pune to Mumbai to Karad. So in a week I gave around 6 exams of entrance. And then I traveled. And then after around, it was not like how NEET is happening. The results are haywire. They come after 6 months, sometimes after 1 year. That time the timeline was fixed. You do an exam, the results will be out in 15 days, and next 15 days you are supposed to join. So after that 15 days I got exam. I got selected in 3 of those entrance exams. Others were also ranked, but they were waiting list kind of thing. Now the issue happened was counseling. There was separate counseling for each college, each exam, and each place. And the counseling was in person. There was no online mode. I said that internet was still developing. WhatsApp was non-existent. So what we had to do is to go and personally visit that college. And sit over there for the rounds. The rank list would be there. And then the counseling process will start. Then there will be a questionnaire whether you want here, you want there. And there was no clarity as such till you reach the place. When I got selected in 3 of these entrance exams, all 3 of the counseling were on the same day. This was another problem. So then I had to choose which one to go, where to go. So I thought that Maharashtra being closer, and I speak Marathi as well. So I said Maharashtra will be a better option. So I went to Pune for counseling. When I went to Pune, there was always this politics with the rules. So they used to ask that 10th and 12th should be from that state. Suddenly the rule is to be there that it is allowed. So the rules were at the last minute changed. Just like how it is happening now, people are going into court case. So same thing has been going on.
You came to know when you went there.
Yeah, this I came to know when I went there.
It's tough.
It's a tough thing. So when I went there, then still they allowed it because it was from the All India quota. It was not from the Maharashtra quota. So once I went to the All India quota, I was getting 2 or 3 colleges in Maharashtra. So the closest one was in Miraz. So then I ended up choosing that. I had no idea where Miraz was. I was unaware of the city, and first time I had heard about that location.
So you never been out of Goa before that, sir, or you had been?
No. I just travel holidays.
Holiday, not for
a long time.
Yeah.
So then I drove all the way from Goa. Me and my dad went to see the college first. Or exactly like not to see the college. It was the day of joining. Packed the luggage, went directly to the college, saw the campus, got admitted, dad left. And that's where my journey began. 5 years in the medical college out of state, that's where you develop. That's what I believe, that when you stay away from your home, you stay in an independent environment, you develop in lot of ways. You learn a lot of things, you mature as a person, you develop as a person. And that's where important things or important decisions of your life are created.
Yeah.
So 5 years or 5.5 years of my MBBS, my life I spent there. After that, I went for coaching for PG preparation. Like everyone who is there, who is preparing, after MBBS, it automatically puts you in that line that you have to prepare for a PG seat.
Yeah.
And then you have to go into a PG. No one knows why you have to do that or what are the other options. And still, I'm in the generation where the internet was not there. Even till my MBBS was cleared, internet has not yet developed.
Okay.
So after that, I went for a coaching. Two options were there that time. One was Bhatia, that is still there, I guess.
Yeah, Bhatia was famous that time.
Yeah, and DEMS. So you choose either of those two. And then again, nearest center was Pune. So I chose Pune. DEMS was already full, so I took Bhatia. It was a 6-month thing, which classes on weekend. Extreme marathon classes starting at 6 or 7 a.m. And ending at 10 o'clock in the night.
It's too much.
Yeah, it's too much, but it prepares you in a way.
Yeah.
It
Competition is such.
Yeah, absolutely. Yeah. So it prepares you in a way, it makes you habitual for sitting. It makes you sit for long hours.
Yeah.
So once you are used to sitting for long hours, you can read a lot. You can prepare a lot. And then it is not stopping you. There are no breaks, very few breaks in between those classes. So that helped a lot. So 6 months I spent in Pune for the preparation. During the time I was working as a small jobs in ICUs or OT as a locum doctor. That's where I got initial exposure to critical care.
Okay.
But I was still not aware ki what is happening. And as an MBBS doctor, you get jobs only in ICUs or a casualty officer, not more than that.
Okay.
After 6 months, I moved back to Goa and I took a job in Manipal. Same time I was preparing for the entrance. Entrance was scheduled maybe next year. 6 months I worked. I learned a lot. That was a lot of practicality involved. I was working in the cardiac ICU of Manipal Hospital, Goa. During that time, I saw what are emergencies, what are the drugs, what are the medicines, how you tackle, what are surgeries happening, everything. Basically, all what we learn in medicine. It was like a second internship which helped me.
Yeah.
So after that, I started giving my entrance. I qualified. And I took, I got in Goa, I got in Maharashtra, same again. No need, same entrance assess process. You have to go physically, be present there. And there's a story how I ended up in Goa.
Okay.
See, I done my MBBS from Maharashtra, so I am eligible for Maharashtra colleges. So when I went for the counseling, on the day of the counseling there, they declared that you have to have a domicile, 10th and 12th from Maharashtra. Okay. On the day of the counseling.
On the day itself.
On the day of the counseling.
So how come so they, on the spot? Must be a lot of pressure that time, no?
Absolutely. You cannot imagine the image of pressure.
Everyone especially after taking 1 year break for studying, it's too much, the pressure.
Absolutely.
Yeah.
And then the situation was very tense. Everyone involved, there was a ruckus. But then they handle it in a way that you cannot. And what you can do, it is just happening in front of you. You either take it or you don't take it.
Yeah.
There are the court options is there, but that is afterwards. That is secondary.
Time, yeah.
It takes time and it doesn't give the result. So after that, I had to come to Goa. In Goa, I came to know that there is one more category where you can get into Goa Medical College. So from the entrance itself. So when I came to Goa Medical College, I inquired, I got through that. And when I went for the counseling, so the major seats which I was getting, they were already gone. This was in the 3rd round or something. I had option either to waste a year or take a seat which I was getting.
Okay.
My interest was there in critical care and I had interest in this field. So anesthesia I was getting.
Okay.
And I chose it. And I chose it. I liked it and I still enjoy it.
Yeah.
So after that, I realized that there is one more process called a bond in Goa.
Okay. Yeah. I think that was 3 years or 1 year.
No,
right?
it was when I started, it was 3 years, but that year they changed it to 1 year.
Okay.
1 year compulsory, extendable to 3 years. So I did my Diploma Anaesthesiology from Goa Medical College. 2 years of intense hard work, continuous duties, and residency. I believe it nothing like anything across India.
This is specially for anesthesia, or it's like common thing for all the branches you're saying?
I believe it's common for everything, but I think that anesthesia was very good and very learning in Goa.
Okay.
So after that, after clearing my DA from Goa, I did 1 year of senior residency and from Goa Medical College as a part of the bond. That time, what happened, the DNB exam was there because you knew after DA either you give for MD or you give for DNB. And that time, this common entrance exam has just come. It was the first year or second year of that.
Okay.
So it was NEET only for both. You can take this one also, but if you're doing secondary DNB, there was another exam.
Okay.
So I gave both the exam. I had this niche of giving exams now, and somehow I ended up clearing those.
That's the best part, sir.
Yeah. And I was always making my way through all the rule books. So if you ask me, I have read all those rule books, whatever, even I had to read laws to go into this. So it was a very tough way to get into it. So to help me financially better, to practice this, I had to join a medical college to be able to practice or to learn more about it. Secondly, I also needed a source of income to manage or maintain myself. That's when I got an excellent opportunity again to my alma mater, BARC Medical College in Mirrors. After that, I answered my secondary DNB, and secondary DNB counseling was happening before this counseling. So my life journey has been always like this. So counseling dates coming into, they're coinciding. So I did that secondary DNB, and luckily I got into the topmost college.
Okay.
It is a Baba Atomic Research Center. That's the full form of BRC.
Okay.
It is a central government, not even central, it is directly under PMO.
Okay.
And it is a sister concern of Tata. Tata group of hospitals. So all that part is interchange. Knowledge sharing is happening. It's a beautiful campus, top security, and we deal with the brilliant minds of India.
Okay, so we just made it short form, sir. The long form is like aura itself. Okay.
So when I entered that place, and just before that, I had seen that episode of Chernobyl. So when I entered, I saw the atomic reactors for the first time. I get that vibe of it. Then I entered it. It was a very good and a different environment. Different from GMC, which I'll tell you in depth later. Okay. And then after that, I did 2 years of secondary DNB. And after secondary DNB, during that time, I got interest into pain. When I joined secondary DNB, there was a question which so many people and so many of you must be having. Why MD? What is the DNB? What is the difference? Same questions I had. And even I was not aware what is the difference. When I went to DNB, I came realize that DNB is even more tougher than MD. It is a central exam. It is not an institutional thing. It is an all India thing. And you are prepared to face the reality in a much better or complete way. So when I went, it was more of a case specific, more of patient specific, the care, the way, how algorithms work. There was a separate protocols. So we followed a systematic pattern in that, which shape you into handling any emergencies later on, which make you a better doctor. So I believe that DNB is very important to crafting you and making you a better doctor. After that, I went and I did my fellowships. I got interested in pain. So I went in search of it. There were only limited institutions who were offering pain fellowship. And I liked history. So I started Googling what is pain, who started it, what is happening. Seems like you people are not aware of pain. Even I was not aware. So I had to take so many years. I even did anesthesia. I was not aware in Goa. When I went to Mumbai, that's where the awareness struck. So when I researched it, the history is very old. It started in 56 in Western countries. India, it started in almost 70, 80s. But still the awareness part was lacking.
It still is lacking.
It's still lacking, but still it is coming up.
Yeah.
Then afterwards I found out who are the topmost people who are practicing. Then I found one center in Kolkata which is offering fellowships, 2 person per year, and there is an entrance exam for it again.
Okay.
So I cracked the entrance exam. This was before the DNB results.
Yeah.
And as soon as my results were out, I completed my term and went for the fellowship.
Okay.
This was in Kolkata. I spent a year in Kolkata.
Okay.
Learning all the pain interventions, minimal invasive procedures. I worked with Tata Hospital in Kolkata.
Yeah.
Here we used to do a lot of cancer pain. That's when I realized that pain is a very broad branch. It has 3 parts. One is chronic pain, one is cancer pain, and third is rheumatoid or musculoskeletal pain. So to learn it better, I did another couple of fellowship into cancer and palliative care and clinical rheumatology. Okay. Then once I started my practice, I realized that there is a lot of things which are missing. Lot of interventions are temporary. So we need a solution for a longer term. And that's when I went for endoscopic spine. And then I got a training in endoscopic. Then I cleared a few of the more entrance exams, few of more training into that, hands-on workshops, and then I started my practice. After this, I applied as a consultant. So I applied for vacancies, jobs in corporate hospital. That's what we do. So what in Goa usually we do is apply in posts in Goa Medical College. We apply for short post or consultant post or lecturer post, whichever comes. But once you are out of the system, you already completed your bond and you have a whole variety of options available in front of you. So you can just choose. So that's what happened with me. And there was a vacancy floating around on the WhatsApp group. I just happened to apply it. And there was an interview happening and I got through it. And I joined and I was appointed as a consultant in Fortis Hospital in Mumbai. Still, I had no idea. I have come from government. I worked in central government and always in the government setup.
So this is a private setup.
This is a private setup. So this is a proper corporate setup. After this, after I joined the hospital, it was absolutely awesome 2 years of my life. It really shaped me as the person which I am today. The 2 years in a corporate hospital, it developed you, it makes you fearless, it gives you courage to work in the setup. So after that, I realized that I need to do something of my own. And to do something of my own, I have to gain an experience in that field first. So I thought that I'll go and practice more in the pain direction by continuing anesthesia as an option with pain. So I ended up there, and with another consultant over there, we started Department of Pain in the medical college.
That time. That time. You started it.
Yeah, I and one more of the senior consultant.
That's very nice.
Yeah. So from there, and I was also working with another private hospital over there. So with private medical colleges, you can have this option where you can work part-time with the medical college and part-time with the beyond your duty hours in a private setup. Government medical college, that option is slightly restricted, or you have to apply for an NPA. So after I did that, I did that stint for almost 1 year. And now after 1 year, there came a phase in my life where I decided that I should move back to my hometown. And I moved back to Goa. Coming back to Goa, it was very clear for me that I will start my own setup and I will give my services to all the hospitals or whichever hospitals are welcoming and try to set myself in the Goa. And that's how I ended up starting my own center, which I own. I am currently run a Revival Health Clinic, which is a general and pain specialty exclusive center in North Goa based in Kolwale, which offers diagnostic, daycare facilities and minimally invasive procedures. And also I am attached with 3 of the topmost hospitals in North Goa, being Vision, Redkar and Sangolda, as an anesthesiologist and a pain physician. So that has been how I've been reached.
It's a very, you can say, tough as well as very enlightening journey. During MBBS, many of the people don't actually have anesthesia as a first choice, or they don't really have any idea. So how about you? Like, how did you get that idea, and was that your first choice always?
I totally agree with whatever you said.
Yeah.
The problem is that when we are into this thing MBBS, your options are medicine or surgery.
Yeah.
Because that is the only thing we know. When we start in first year, we start with those 3 subjects: anatomy, physiology, and biochemistry. We learn about anatomy, so we think that it is more of surgery.
Yeah.
Then we learn of physiology and biochemistry, more of medicine. Then here is the point in even first year where you can make a decision. If you are liking the incisions, you take surgery. If you are liking more of this reading and more of that, you take medicine.
Yeah.
After that, you go slowly, second year, third year, you don't get any idea that there is a field called anesthesia. When you come to final year, even if the postings are there, they are very short postings to understand.
You're only worried about the science.
Yeah, we're only worried about the science, and mostly you are busy in your other works at that time. So that is taken as a granted option. Secondly, when you reach in the final year, there is a paper for anesthesia that is also attached in a surgery.
Yeah.
So it is very few marks. So again, you can either read about it or very skippable questions.
Yes.
Then you go into internship, and that's when you realize there is something called anesthesia. Most of us, our first interaction with anesthesia comes during ortho posting or surgery posting when fitness is not given. That is what has happened with me.
Yeah.
Our seniors from ortho or from surgery, they used to shout, you have to get the fitness done. Till then, we don't know what is fitness.
Yeah.
For us, fitness is taking the paper around and getting the sign done. Correct?
Yes, sir.
So, what this fitness was, why it was important, totally unaware. So, during ortho postings, we used to run with the files for getting the fitness, getting the patient fit for the surgery.
Yeah.
All that, everyone has done that, everyone is doing that.
Yes.
So, during that time, we enter OT properly. We get to scrub. We see around what is happening. We spend a good amount of time in the operation theatre. And that time, we spot a person who is sitting there. He is sitting in the corner, he is enjoying, and he is relaxed. He is totally unaffected by the things what is happening.
Yeah.
And you become curious, who is he? What is he doing? And why is he there? And why is he required? So that's when you think, you talk, and then you come to know that entire surgery is possible because of that person who is sitting there.
True, sir. True.
Okay. So then when you start, when you are operating, we are assisting as an intern in ortho or surgery. I will not say in anesthesia because you get very less opportunities for it in your short stint.
Yes, sir.
But when you are seeing, you see so many times that lot of things are happening to your patient. There are hemodynamic fluctuations. There are difficult airways. The cases are difficult. You know patient how bad it is.
Yeah.
But still the case is happening, and you realize that it is possible because of the person there. Then you see the fancy gadgets over there. You see the machines. You hear the sound. And then you see that lot of things are happening here. This is not normal.
Yeah.
And you enter into a very different area of your hospital. Maximum time as a college student, as an MBBS student, or even as an intern, you don't spend in this area. But during internship, you spend quite a good amount in that area. And that's when you try to explore the things.
Yeah.
You get the idea what is happening around. And that was my first interaction or a first glance to anesthesia. Even just like you said that you skip anesthesia.
Yeah.
That's what happened to me in anesthesia posting. You won't believe it. I had skipped anesthesia posting. And then I had to redo anesthesia of the 15 days. What do you call it?
Extension.
Extension of 15 days in anesthesia.
Okay.
So I have done anesthesia posting twice. Maybe the destiny was in the favor.
It was a signal.
It was a signal. But still, anesthesia was far away from the mind. Maybe I was into surgical more. And then after that, from when I did for preparation, we read a lot about anesthesia. Then it interested me. So whatever interests me, I go into the history of it. So when I went to history, it's a very simple idea and a lot of people can follow. See, if you want to know something, you should dig about its history, why it started, why it's happened. Once you dig about the history, if you get it interested, then you'll like it. And once you like it, you will forever keep it. So when I went into history, I came to know that anesthesia was non-existent.
Before,
almost 100 years, 150 years, it was not there.
Okay.
Yeah, people used to just hold, tie, do anything and knock off. any ways to knock off. Even alcohol was tried. People used to pour alcohol till he is banged off. And then it was not a practical way. Anesthesia was discovered by accident. There's an interesting thing. Everyone knows about cocaine. Cocaine is a drug. So this one dentist had kept this drug, I don't know, for some medical purposes, on the table, and a fan or breeze was blowing, and some of it blew and went straight into his eyes. After some time, his eyes felt numb.
Okay.
So he realized that this is not normal. So he went into research of it. What is it? Why it is killing? So then that's where, from that cocaine, all these cane anesthesia agents were developed.
Okay, sir.
Same way. So it is just an accident how it started, and then it has progressed into that. So again, still we are there, but these are like 10th generation of the same drug. So we are just purifying the same drug and it is happening. But now there are protocol based now, which is the way it is happening. Secondly, when I was working in the Manipal Hospital, I was working in cardiac ICU, as I said before. There was an incident which attracted me towards this critical care. Me and one more of the RMO over there, I was the junior most, as I had just finished my internship, happened to be on duty, and suddenly there was a code blue happening in the same setup. Code blue is when there is a cardiac arrest situation or an emergency in a corporate setup. There are various codes which are, of that code blue is important.
Okay.
So code blue was announced. So it was a panic situation. Patient was crashing. There was heart rate was around 10 or 15. BP was not recordable. Patient was not responsive. It was absolute panic. Everyone running around. Sisters are preparing something, and we as a primary physician were not in the state to do or intervene. When code blue came, a team of doctors, one doctor and some assistant, they rushed over there. They were calm as ice. They went, they intervened, they intubated the patient in seconds. They put a line, they put a central line, they put a arterial cannula, all this within 2 minutes. And they stabilized the patient and they left. They left as soon as they came.
Yeah.
So I was in awe, what is this happening? I had never seen such a scenario, or I had never experienced. So that's when I asked one of the senior brother from the ICU. He was a Karenite. So I asked him, who is this? Who are these people and who are they and what happened just now? So he told me that he is the person for which can prevent you, or is between you and death. So that word stuck with me, and that sentence stuck with me forever. And back of the mind, critical care was one of my options. So when I went for counseling and when there was DA option available, I took it.
Okay. While choosing the anesthesia branch for NEET, like for PG, sometimes students have this doubt that there is certain lack of job satisfaction. Like people want to operate, and sometimes they feel that they are in the OT and they are seeing the surgeons operate, but they are not able to operate. So that job satisfaction, will I get or not? So certain doubt is there. So is that something like that? Or if you think like that, what is the solution? How do you cope up with that?
Totally agree with you. This is a very genuine question. And even I had faced this. And I'll tell you why it comes. When you go into anesthesia and when you are starting in your JRship or a residency, when you're first year resident, you are posted in different departments or different OTs. You are posted in surgery, you are posted in ortho, you are posted in gynec. So you are only doing the anesthesia part, you are not operating. But when you go out and you tell your parents or you tell your relatives, if they are not from a medical background, they don't understand. Okay, when you tell you are posted in surgery, so your next question you will get is that, are you operating? When you tell that you have done a cholecystectomy or you have done this, so their question is very good, you did a cholecystectomy today. But you are doing the anesthesia part of it. So when you realize this, then you find a way. For me, what happened was that my way of understanding me was that without me, the surgery won't be possible.
That makes sense, sir. Yeah.
So without anesthesia, that surgeon would have not been able to operate. And now anesthesia has developed so much. As like I have done my fellowship in pain, so I am doing endoscopic spine surgeries or endoscopic spine procedures or intervention. They are almost on the other side. So those advantages now are there. So even if you feel after your anesthesia residency that you are on the other side and you want to go on the skip, this is the option and you can cross over.
Okay, so it's all about that perspective, how you look at it.
Absolutely.
So you can either think that surgery is going without me, I'm not able to do anything, or you can think that it can't proceed without me. They have to wait for me to get there and start it. So like that. So that's how. So perspective is important. You can't think anybody is inferior or superior. Okay. Sometimes people want to do surgical and they don't get surgical branches. Then they think the anesthesia is next close relative of the surgical branches, and they think it might be a bit on chiller side, and they don't know that how hectic it can get. So how hectic it can get, and how were your residency days like can you just give us the idea of like you as a first year JR, the kind of things you have to do, how hectic it can get, the night shifts and the kind of time to sleep you get and all that, so people get that broad idea.
When you are in anesthesia, you are on the other side. That's what people say. I never figured out what is the other side and what is the other side. We used to joke about it is as a blood-brain barrier.
Okay.
Blood on one side and brain on the other side.
Yeah, I'm hearing this first time, sir. What is the other side actually? Okay, you're getting to that.
Yeah. So other side is that blood-brain barrier.
Yeah.
So if you have gone to OT and you see there's a shit inside, which is tied, which is separate from here on the patient's head end and the operating field.
Okay.
Okay, there's a division, there is a curtain in between partitions. So on the other side, there is all bloody surgeons, and on this are all brainy anesthetists.
Yeah.
So that is how you can figure out.
Yeah.
So that is a joke going around in the community. But on the serious note, when you go into anesthesia, this doubt stays with you for the initial 6 months. Okay. There is an adjustment period. It's usually from 21 days to 30 days when you join any branch. Not only anesthesia, it's for any branch. Even if you take a surgical branch, there is always a confusion whether you wanted to take a surgery, you wanted to do OBG, or you wanted to do ortho, or any other different branch.
Yeah.
But once you get into that adjustment phase, which takes around 21 to 30 days, you believe or you continue in that. With anesthesia, the maximum residents who take anesthesia, they end up completing it.
Okay.
The dropout rate in anesthesia is very low.
Okay.
This thought is before joining, where you were thinking that the surgery would have been better option or anesthesia. But once people have joined anesthesia, if you asked any of my colleagues or even if you ask any anesthetist, their first choice might not have been anesthesia. But if you ask them now whether they love anesthesia, everyone will answer with a positive. Maximum people or almost 90% people continue anesthesia, they enjoy it, and they get awareness how good the branch it is. Coming to residency, residency as I believe it should be in all departments, it's very intense. In anesthesia, it shapes you as a doctor.
Yeah.
Okay. There are long hours of work, long hours of duty. Your day starts early in the morning with pre-operative rounds. Then there is preparation for the OT. Then you do OT or operations. How many are scheduled? Then there are emergency cases which come. Then there are pre-AC or fitness checkups which happen. Then there are critical care postings. Then there are on-call duties. So all this is part of the residency. Hours cannot be described, but they are always more than you think.
Yeah.
So if you are thinking that your shift is gonna be ending at 5 o'clock, it will never end at 5. But that I think it is most for the most clinical branches.
Yeah, but here, sir, you can't complain because this is related to more of emergencies.
Yes.
So you have to be there.
Yes. You have to be there, and you are dependent again on the surgeons till they finish. Even after the surgeon has left, your job is not over.
Yeah.
Your job is with the patient till the patient is out. Out from anesthesia, out from the OT. So you are a complete physician. You are pre-op, intra-op, post-op. And also after that for pain management part. So once you go into residency, you get adjusted to this. You get adjusted to first learning how to handle stress, how to communicate, how to be in a team. These are the most important part of being a doctor. And if you master these three, you will be very successful in your future careers.
Yeah.
Teamwork, you know how to handle your seniors, you know how to handle your juniors, and most importantly, you know how to handle your patients. Then you are a complete doctor.
Sometimes handling patients is the easiest part, sir.
I'll disagree on that. See, I'll tell you why. There is a reason for that.
Yeah.
See, when a patient comes, you don't know what the patient is. If it is under the anesthesia, it is the easiest to handle.
Yeah.
But if he is awake, he will have doubts, he will have concerns, he will have irrational thoughts, he will be scared, and you are the only person who is between him or who is the contact of him.
Yeah.
Whenever you are advised of surgery, see, if somebody is advised for surgery, he is scared. First thought is
Definitely,
scared.
Scared.
He will ask family, everything. It is never planned. Very few cases planned, but maximum it is not planned. You go for something, it got diagnosed, and you end up in a surgery.
Yeah.
So lot of things are going on in the patient's mind. Patient is in a thought, he has not slept, he has not eaten well. Only person who cares about this will be the anesthesiologist. During fitness, he will inquire everything.
Yeah.
He will determine everything. His duty is to optimize you and make you safe, keep you safe, and build up a trust between you and him. That's the most important part.
Yeah. Okay.
One more advantage of being anesthesia, if you go in the OT, so these surgeries, most of them, they go for long hours. And you are constantly standing. So as a surgeon, you are constantly standing, operating, you cannot afford breaks. But as an anesthetist, you are allowed to sit. So you'll be comfortably sitting. That is one advantage. Second, you will be able, somebody or the other will always relieve you for your breaks. You can have, they will be always concerned. And all anesthetists worldwide, they will look after you. Wherever you join any institution, that community is always there.
Okay.
So
that is a good part, sir. I have not heard this kind of community-centric branch. Okay. And what about this ICU setting, sir? How intense it can get?
See, just as the name suggests, it's an intensive care unit.
Yeah.
So just like I told you that operation theater is a different area altogether. ICU is another different area or a different part of the hospital. ICU more or happens is that there is a word called critical. So again, most of the people are not aware is what is critical. We use it left, right and center.
Yeah.
Critical. Critical is when we cannot manage our own self. Okay. So make it even more simpler. We cannot manage our own hemodynamics. We cannot manage our own respiration. We cannot manage our own GI system or our body system. That is when we get into a critical phase. Understood? So once in a ICU setup, it is basically a complete monitoring unit where you have your BP, heart rate or vital monitors are continuously monitored. Your respiration is monitored. There is ventilatory support possible where you cannot maintain your own respiration, that possible. Your input output is measured, your GI. So in a simple way, a complete monitoring setup of a human body with aim to get him out of that situation.
Yeah.
Understood. So in this critical, you do a lot of procedures, you do life saving, be very vigilant. And vigilance is mainstay of anesthesia. Either it be in OT or it will be in ICU. Within seconds, it's a matter of life and death. So quick decisions, vigilance, communications, and early alarms. That is the way. In ICU, lot of things are more of algorithms and protocol based. There are protocols for everything. And most of you are not aware that they are rehearsed. Just like a fire drill which happens in school, there are drills which happen continuously almost on a daily basis. There are drills for a crash means patient arrest. There are drills for difficult intubation. There is a protocols in place. So that minimizes the panic.
Yeah.
So everyone of the team, I said starting only, that's a teamwork.
Team.
So everyone in the team knows their role. They guide you. Everyone is there for the help. So everyone, that's why it's a community based or community centric, where you require a lot of people to make it happen.
So as you said, I think a lot of people don't understand why ICUs are there, what critical ward means. Because recently I had seen a televised video where a doctor and a reporter had asked him, like, people think that the doctors are keeping patient just for the sake of money. They are admitting patient is dead. That's what they think. They don't understand that he's on support.
The problem which I see is because our ICUs are in a closed setup. Same with operation theaters. You are not allowed to enter it. A lay person is not allowed to enter operation theater. Even we as a doctors, we enter during internship or postings. Otherwise also we are not allowed to enter. Same with ICU. During internship is the first glance when we enter ICU. So for lay public to understand, it is even more difficult. The problem happens is because more, I believe, is because of the media and the films which show. Because there is no concept of sterility shown in any of the movies which I have seen now, whether it is a Bollywood or a Hollywood movie. Okay, so because they have not visited inside, they are not allowed to see inside. They have not seen how the cases are planned, what is happening, and it is labeled as a theater. So there are a lot of actors, a lot of people involved to make it happen. So that is a complete way. When it comes to ICU, you are allowed to visit for a small duration. So when a public or a person's relative is admitted, you go inside, you see around, it's a new setup, everywhere it's buzzing, there are sounds. You go and you are first of all lost where I have entered. Before entering, you are made to change your gown. See, if you are a normal person, this is a very different thing. They don't understand why you are made to wear a gown, why you are made to wear a mask, cap, why the change of slippers. It is for infection control. But that awareness is lacking. So those awareness starts from that point itself. Once you enter the ICU, you are directed to your patient. You see that there are a lot of people, a lot of admitted patients on there. There are few here, few this side. They are busy, a lot of things. You are seeing this for the first time. You have no idea what is happening with anyone. So you go directly to your patient. You try to see the patient, but you don't recognize him at this point. Maximum, because this is what from my personal experience I'll tell you. When you see your patient in the ICU setup, he is different. He's shaved. If you have a beard, he is clean shaved. He has tubes inside his mouth, inside his nose. There are IV lines connected. There are a lot of things in monitors. There are wires attached to them. So people get confused what is happening. And they don't understand what the numbers are, why it is buzzing. So there where with more the information, misinformation spreads faster. When you go, then what happens is that the ICU in charge or ICU doctor, he counsels you. He tells you that so and so a thing has happened. You are not aware because everything has happened inside. They must have taken your consent, they must have explained. But then by the time you come, somebody, other person or other relative has walked in. That's where the chain breaks. You counsel properly, you document it, but the person who has documented or whom you have counseled is the second person. Or maybe the other relative is there. And that message has not been passed to him. That's where the misinformation and most of the problems start. Then they go inside, the patient deteriorates. And in ICU, patients are critical already. So always we prognosticate and keep that patient can deteriorate because it is not in our control.
It's true.
And once they deteriorate very fast. Means it's like in seconds the patient can be gone. And then it becomes very difficult to explain to the relatives. And once you explain suddenly that they say that I just saw him 5 minutes back, he spoke with me. And now he's gone. How is it possible? So communication skill is also part of anesthesia training. And it becomes very important. So a lot of this miscommunications have to be attended to. There are a lot of education and a lot of media involvement, and it has to be a complete society role. So after that, that is there. And I can guarantee you that nobody will like to admit a person just in case for money making. Because because there are if it's an ICU setup, it's a limited resource. If I have 25 beds in ICU, there are more 25 patients waiting outside to get into it. Only after I get a bed vacant when I can admit a new one. Same it is across all hospitals. If you go into any hospital, the hospital might be a 400 bed, but the ICU setup must be above around 40 bedded. So it is a limited resource and very expensive to manage. So simply for money purpose, I don't believe it must be happening.
No, it's not happening. So it's just a rumor spread.
It's more of a
Yeah.
misinformation,
Yeah.
and it's spreads because of a communication gap and misinformation. So no.
Yeah. And sir, according to you, like, what are the most stressful situations anesthetist faces when he is in OT? Some of the most stressful situations.
See, stress is another name of anesthetist.
Yeah.
So you are daily handling stressful
Yeah.
situations.
Yeah.
So when you are training as an anesthetist, you are trained in a way to manage this. You might be seeing everyone roaming around, coughing, drinking coffee, or eating, or just talking with the surgeon, or there are any other thing is happening, or reading. But once they see that something happened, immediately within seconds they are alert. They will respond to the situation. How it happens is because we are trained in such a way, we follow algorithm, we follow a proper protocol. When you go for a stressful situation, there are three major stressful situations in a OT in any case. One is airway, difficult airway. If you cannot secure airway, you cannot save the life. Second is intra-op cardiac arrest. Patient is taken on the surgery is going on and the heart stops. Sounds scary.
It's scary.
So that's what. So you
Yeah.
trust the anesthetist fully.
Yeah.
Third one is anaphylactic or allergic reactions. This can happen.
Yeah.
And most importantly is the hemodynamics in the emergency case. You don't know, you never know what will come through the door. So stressful situations is how you manage it. See, the most stressful situations I'll quote is that I had done a 700-gram baby.
Okay.
700-gram baby. I think when you go to a chicken shop, chicken is more than that.
Yeah.
So to get an IV line and to manage it, and it was an emergency surgery. We managed to get everything done. But this is something you are not trained ideally for. This you read and then suddenly it comes. Or there is a case where it's a difference between two lives, like in a pregnancy case. So you must have heard so many times in the movies कि एक ही को बचा सकते हैं, माँ को बचा सकते हैं या बच्चे को बचा सकते हैं. But in reality it is not.
Okay.
We try to save both because it is inside one person. We are dealing with two lives.
Yeah.
So we always try to save both. But most of the time what happens is there's a delay in the patient reaching to us.
Okay.
So as an anesthetist, you deal with life saving. As I said, you are between the patient's life and death. You save, you intervene. That's where the critical care part comes in. So we are daily dealing with that. And once it's a team and once there's a protocol in place, it becomes much more simpler to handle it.
So as you said, anesthesia is synonymous to stress. So what kind of personality traits should be taking anesthesia and who should not take it?
So you should have love for physiology and pharmacology. That's the first prerequisite. Even in your first year or second year, if you love physiology, you like to read about it, what is happening in the body, and then you are more interested in the pharmacology, all the medicines, whatever is happening, how they are reacting with the body. So you're combining physio and pharmac, then it is for you.
Yeah.
Second, the art of being calm in a stress situation.
That is difficult.
So if you want to master that, join anesthesia. Absolutely.
Yeah.
So once you are into anesthesia, your decision making will improve. So if you are very panicky, it will automatically bring you into a calmness.
Okay.
That's what I said. The dropout percentage is very less in anesthesia. Even if you think that you are a very panicky person, but somehow in the training you adapt, you change, and that helps you in the life. So many times there are family involved, any emergencies involved, you are the first to react.
Yeah.
And that becomes part of your DNA. You just jump forward to help. So that is one. So yeah, that is requirements. You should be calm enough. Not a total
Over panicky person.
over panicky person.
Yeah.
If it's a over panicky person, then it becomes, you should be able to act more
Yeah.
in the panic
Yeah.
situation. So if you are able to act in a panic situation, you are fit for the job.
You cannot freeze.
Yes.
Yeah.
And third thing is most important, whether you are a lone player or you work in team.
Huh.
Anesthesia is more of a teamwork.
Okay.
So you have to understand, you have to be a team player. It's like a sport. It's an individual sport or a team sport. Which one you like? If you like individual sport or if you like team sport. If you're more into team sport, anesthesia, you're welcome. So it's because of a team environment. So these three things. One is love for physiology, pharmacology. Second, being calm in stressful or taking decisions in a panic situation. And third is teamwork.
Teamwork. Okay, very well said, sir. Sometimes the general perception or general people don't understand what exactly is anesthesia. So can you just explain us in our simple terms to understand better?
Absolutely. So when I was working with one of the neurosurgeon, we did a case. After the case, he called me to his home for a cup of coffee. I went to his home for a cup of coffee and his 7-year son was there. So his father told the son that he is Dr. Kaushal, he is the anesthesiologist. So he asked his father, Daddy, what is anesthesiologist? What does he do?
Yeah.
So I had to explain it to a 7-year-old child, ki what is anesthesia? And I was sitting in their living room and there was some video playing on YouTube video on their TV. So I realized that anesthesia is like a YouTube video. It's playing on. What the anesthetist does is it pauses you.
Yeah.
So it pauses the video. You are not aware what is happening. In that pause fraction, all the job is done. The surgery happens, everything happens. And afterwards, the anesthetist goes and restarts the video. So that's the simplest example of what anesthesia is.
Yeah.
So basically, we are just pausing your physiology for some time so that in a controlled environment, so that the surgeon can operate on it.
Yeah. That's
Okay.
Okay, very simply put, sir.
So in that, once we go into anesthesia, it is not that simple.
We are not 7-year-olds.
We are not 7-year-old. So it is very high tech, it is very advanced, and the modern anesthesia is very challenging. So, but more safer than it was like 20-30 years back.
Okay.
So when you are giving anesthesia, basically there are three ways. One is general anesthesia, where you are completely knocked off. You don't remember anything. You are steered, your airway, everything is under the control of the anesthetist. Second is regional. Regional is where the medicine is put in your spinal column. So either it is in the subarachnoid space, which is spinal anesthesia, or in the epidural space, which is epidural anesthesia. This is mostly done for the abdominal or lower limb surgeries or for pain management. Thirdly is regional blocks. So as an anesthetist, we are able to identify which nerve supplies which part. And then we are in a position that we can find it, select it, and we can block it. So these are the nerve blocks which have come. And with the upcome of modern technology, this has become much safer for the patients.
Okay.
So when we go into this, if we go into detail, when we go into general anesthesia, there is no absolute contraindication for general anesthesia.
Okay.
So if any patient is high risk, we just optimize it. We titrate the drugs or the medicines according to it. We take precautions in a way so that it becomes less of a risk for the patient. So general anesthesia now has become way safer than it was many years back, with the technology, with the drugs, with the machines, with everything involved, with the training. We can do all major surgeries under that. Second, regional anesthesia. So in regional anesthesia, we have this spinal and epidural, which is for our lower abdomen and lower limb surgeries and for pain management. And then there are regional blocks which we can give for upper limb or selected lower limb procedures, so ankle blocks, or most of this can be done for scalp. Even we have been doing awake brain surgeries under this block. When the patient is, you must have seen a lot of videos circulating.
Yeah.
Person is sitting in the operation theater playing his guitar, surgeon is operating, brain is open. How is this possible? And patient is not complaining of pain.
Yeah.
So these are blocks, skull blocks we do. So after that, the incision is done. It's completely pain-free. Patient is comfortable.
Okay.
Then with this advantages, we can do it much more in safer and much more precisely.
What are some of the misconceptions regarding anesthesia when general public have? Or myths, let's say.
So we'll go with each type of anesthesia.
Yeah.
So in general anesthesia, there is a fear that his brain will be erased. All memories will be gone.
Yeah.
Second, he will not wake up. These are fears, and they are being coming because of incidents in the past. Just as we discussed with the history that people were beaten, knocked out, hammered, just to get into that time this thing was there.
Yeah.
But now with the advancement of technology, these things are not happening. The medicines are much more safer. The machinery which we use are much more safer. They are, by the way, they are very expensive. Anesthesia machines, anesthesia setup is very expensive for the hospitals. So no, your memory will not be erased. But yes, we have medicines where we can get your temporary anterograde or retrograde amnesia. That is usually preferred so that your anxiety goes. And we don't want you to remember what has happened with you in the OT setup. Because that is a very bad experience and a very bad memory. And lot of people can have a PTSD or post-traumatic stress disorders later on because of that. So if I can suggest a movie also. There's a movie called Awake.
Okay.
So it is based on that, where patient remains awake during surgery. But now in the modern day science, this thing is almost next to impossible in a control setup. Second, the question is that you will not wake up. This is a controlled environment. I said, just like you pause a YouTube video, we have the button or we have the medicines to get you back up. It might take some time, the delay might happen, but you will definitely wake up. Okay. Third one, in misconceptions in spinal, there are a lot of ladies which ask me that after spinal I'll get back pain. It will continue. The back pain is persistent. So I'll assure you that it is not the case. Previously, 15-20 years, maybe when before the Gen Zs, before that, the type of needle used were different. Now see, if you go around 15 years back or 20 years back, there were no mobile phones. Now the mobile phones have come, now we have internet, it has progressed. So same development has happened in the field of anesthesia. And especially in the last 10-15 years, it has developed very rapidly. So now the needles which we use are finer than your hair.
Okay.
It's like 27 gauge needle. So if you can Google 27 gauge needle, you will be able to see it. It is finer than your hair. It's very fibbly. So even if you hold it, it will bend. That's soft to do. So the problem of back pain with such small needle is almost next to zero. Okay. And third questions which people ask is that after this anesthesia, there is a numbness which is there. Usually we can control the duration of numbness. If in a control setup, the normal duration is 4 hours for a spinal anesthesia max. Or for a block, we can extend it from 8 hours. Or if we are continuous, we can extend it to days also. But again, it is a control. And as soon as the medicine is stopped, you will come back to a normal or original state.
Okay.
So these are only misconceptions. They are just misinformation spreading. So I will like to clear about that. And these doubts, Dr. Pradeep has concealed or concepted all these misconceptions very nicely. So I could address them and make a clarity for you.
Yes, so thank you, sir. So, like whenever you are doing PG, there is often that term, the toxicity, departmental toxicity, or the branch toxicity. So, is there anything when it comes to anesthesia, and if there is, how do you cope up with that? Because it is already very hectic branch, and a different kind of stress, it becomes too much.
I'll address that question.
Yeah.
But to address it first, you have to define what is toxicity. So toxicity is a point of view for a different person.
Yeah.
For one person who is very protocol based, or she must be having one way of doing it. So it's how your senior is, or how your guide is, or how your teacher is. She must be or he must be doing it in a particular way. there is a straight set of things and you want it only in that way.
Yeah.
So if you miss it or if you try to do from outside, that is not allowed. So that is one way. Second way is your punctuality. You should be punctual. See, in anesthesia, it's a critical care branch. So decisions are required in seconds. So if you miss something, it becomes a life and death situation. Most of the juniors, when you come, your basic job is doing monitoring. You monitor the screen, you monitor the vitals. And if you miss that there is some change happening, that's when you might face some action. There is an advantage to it. Once you face action, you remember that why I faced that action. You remember that because so and so thing happened because of that, and because of that this consequence would have happened. So it's a realization for you that this thing is happened to you. Secondly, most of the toxicities in other departments is around the thesis.
Yeah.
It is on the guide. So what kind of guide? It's a personality. There are 1,000 types of personalities in the world. So it totally depends on your luck.
Yeah.
What kind of guide you are gonna do. But now government has made it much easier that a guide signature is not required for going to exam.
I think thesis is not compulsory for attempting exams.
Thesis is not compulsory for attempting the exam. So that part is taken care of. But still, when you are doing a thesis, there's a timeline or a number of cases which are supposed to do.
Yeah.
In anesthesia, that is always done because the load is so much.
Yeah.
So load and your sample size will be done. Maybe you might not get time to edit it, but eventually you will complete it. And I said that anesthesia is a teamwork. So your colleagues will be your best friends.
Yeah.
They will guide you. Your seniors or your juniors, they can help you in that. And there is a team around you also.
Yeah.
It's a theater. So every artist takes part in that. So there is a huge support system. And you are in a control setup. You won't be like individually present in front of that toxic person or toxic person. Most of the department, the problem starts when you are alone with the toxic person.
Yeah.
In anesthesia, that is a rarity. You will always be in an environment where there will be people around you. So that kind of abuses or physical assaults or those kind of things will not happen. Okay. Whatever you might face, or if you call it toxicity, will be a corrections of verbal nature. Those are possible, but this will be in a learning curve. Slowly you will learn to adapt into it. And it will make you a stronger person because it makes you calmer. When you are, what happens is that now, especially in the generation, when the age gaps or Gen Z or whatever now, millennials, whatever is coming up, when the way we used to talk to with our parents or to with our seniors, it is changed. Now people address directly with their names. In medical culture, that was the seniority was existent till now. We were taught in a way that seniority was there.
Yeah.
And we used to respect it. We used to never question why, what. But now it's a good thing that Gen Z is questioning. But they are not questioning in a way with the thing of getting the answer.
Yeah.
So if you are asking a question, you must be prepared to get the question to yourself also.
Yeah.
So it's a two-way channel. So if you ask me a question, even I am allowed to ask you a question in that. And if you answer that, then I'll answer the second question. So that's a chain of answers.
Yeah.
So toxicity as such, long hours can make you stressful, decrease sleep, that might affect you, that might make you lose. But the environment is always kept lively with all the people around.
Yeah.
And depends on the setup wherever you are practicing. So you can ask with the seniors, you can visit the hospital prior to joining. You can get a fair idea.
Yeah.
You can, how I used to do it is that, I advise people, you meet 3 people. One who has been practicing anesthesia for minimum 5 years. One who is in residency 3rd year. And one who has just 1st year is completing or new fresher.
That's a very good advice, sir. Yeah.
So once you get the idea, you'll get idea on all 3 phases. So you'll come to know at what stage you'll be at 3rd year, what stage you'll be at the end of 1st year, and what you will be down the 5 years. So you can take a corrective decision at that point itself.
That's a very good advice and a unique advice, but I think it makes a lot of sense. Okay, but sir, during like anesthesia as such is very stressful, the patients and it's all a critical side. So during your time, did you feel that the critical situation or critical sense getting to you and you felt a bit depressed or something, or if you did, how you cope up with that?
Absolutely. This is part of the medical field in whole. Not only anesthesia, but all fields, I believe. So when you communicate with the patient has a trust on you. He, in a way, hands over his life to you, and you are responsible to take care.
Yeah.
It is unspoken. It is just an understanding that his life is with me. And then I automatically overburden ourselves.
Yeah.
That I have to do the maximum I can.
Yeah.
In many situations, it's beyond our control. In medicine is such a field that we treat, we give medicines, but healing is in the hands of God. Finally, so then it's happened that way, and so many times we lose patients. We have to communicate with the relatives. We have to address. We have to declare that patient is gone. That's when the emotions part.
Yeah.
Especially these things happen when you are in ICU setup. If you are working in critical care, in ICU, how the system is that you work in usually it's in 3 shifts. Okay, 1, 2, and 3, like morning shift, evening shift, and 1 night shift. So you are continuously working. Today you do morning, you do evening, you do night, and that's off. Most of the hospitals follow this regimen.
Yeah.
So when you work in this setup, you see that patient today in the morning setup, you do whatever you can, you hand over to the next person. Again, it's a team effort. The amount of efforts you have put, the same amount of effort the next person has to put. That same has to continue with the third person coming in the night. And that will enable the patient in the same condition or improved condition to you when you come next day in that shift. But this chain gets broken many a times because of various reasons. So once you do, I'll give you an example. I had a patient, she was 70-year-old female, totally healthy. Suddenly she had an episode of breathlessness. One episode, she was rushed, came to casualty with SpO2 of 40%. 40%, so they ventilated, put an NIV, shifted to ICU. Whenever patient is in ICU, we try to delay intubation or a ventilator support. We try to get non-invasive as much as possible. If we see that the patient was very good, she was otherwise okay. So we could manage on NIV. We got the saturation about 95%. So it was working perfectly. Now the next person also has to maintain that chain. If something happens or a small incident or something up and down, the patient gets intubated. If patient gets intubated, he ends on ventilator. And once patient is on ventilator, the problems increase by tenfold.
Okay.
There are other complications which can happen, all that. So we try to prevent patient from going onto ventilation as much as possible. And here also there's a misconception that people believe that we put on ventilator on a purpose. It's ulta.
Yeah.
It's actually opposite. We try to avoid as much as possible.
Okay.
Only if it's intubated means there was no other option available besides intubation and putting on ventilator. Okay. So after that, patient is there. You stabilize. You work on the patient for at least 7 days to 10 days. That's the minimum time a patient spend in ICU. And you form an informal rapport with the patient. After that, suddenly you realize one that the patient is deteriorating very rapidly, and there's nothing you can do. And that's where you start that emotional connect. I have worked on this, I've tried, but it's beyond your control. And then you try to understand what their family is going on. So that's what affects you. And the only way to cope up with this is communication. You are supposed to speak about this. This is also a part of anesthesia training, communication.
Speak to whom, sir?
Speak to whoever is there on the team.
Okay.
It could be sisters, it could be the ward mamas, or caretakers, MTS, anyone. They are also part of the team. You believe that you have worked, but you don't realize that they have also worked on that. they are also doing that same thing.
Changing and all that.
Changing that, there's a lot of hard work. Even they realize that patient is going. Everyone is working towards that patient. That's why I say it's a teamwork, it's a different environment.
Yeah.
So at the end of that, you can communicate because they also have the same stress building up. So each one is relieving each other's stress. Communication is the best healer.
Okay.
And after that, you enjoy very small moments. If a patient is extubated, you celebrate that moment.
Yeah.
If patient is discharged, you celebrate that moment. So if you celebrate those tiny moments, even if you get some samosas or something, that makes sense. So that brings you out of your stress. So tiny victories should be celebrated. We miss it a lot. Even in OT, if you have done a difficult intubation and you are very amazed, but you are in the flow, like case is happening, it is just happening fast, so you don't have time to celebrate. But by the end of the day, you just realize that, I had done that. So you should celebrate it. Maybe go out or do something or whatever minimal, but always celebrate your small victories. That is the best way to come out of stress.
Yeah. We're hearing a lot of unique and very sense making things today, sir. No, it is actually true. Like, I have not heard these things before, but it makes sense now. Like, it is important to celebrate your small victories and then communicate. Don't keep it like suppressed inside.
What I can guide you is whatever I have learned through hard way.
Yeah.
So when we were residents, there was no one to tell us do this, do that. We have learned by watching.
Yeah.
The senior concept or the toxicity concept, whatever came, because it was not a formal way of teaching. You just see, you learn. We learned by observing. Most of the academics happened by observing what our seniors were doing, what our consultants were doing, how they were handling. Because everything cannot be taught. So if you are observant enough, you will learn a lot. You will learn it faster. And you will learn it perfectly. And when once you read it afterwards, you know what is happening. You correct yourself.
Yeah. Okay, sir. Okay. Now we have like discussed a lot about the anesthesia branch, but I think we will discuss more about what you have done in the field, like now more of a career aspects. So what are some of the career aspects that you can do after completing anesthesia? And sir, I was working in a private hospital for a short duration. I had met an anesthesiologist, and what they had told me that you will be connected with a lot of hospitals, and you will be called for different cases, and you will be paid certain amount for different cases. So you have to take cases from one hospital, you'll be called to another hospital. So how does that work?
To understand this, now I'll tell you कि in anesthesia, you will be anesthesiologists are always in a shortage.
Yeah.
Okay. There will be always job opportunities for anesthesia. Secondly, which you should know is time is money in anesthesia. The more time you devote to it, the more you will earn. Okay. With anesthesia, either you can practice anesthesia as a whole, or you can do super specialization in there.
Okay.
Just like I have done in pain.
Yeah.
Other options are cardiac anesthesia, neuro anesthesia, critical care. These are options where you can.
But these are like DMs or these are like fellowships, sir?
These are DMs also, and there are fellowships also.
Okay.
Both are possible.
Okay.
And there are these FNBs also in this branches. So you can do a plain fellowship institutional, you can do FNBs, you can do DMs. So
what is FNB, sir?
FNB is Fellowship of National Board.
Okay.
So it is a NMC recognized thing. Fellowships of institutional are not totally recognized by, but you are allowed to practice.
Okay.
Means only difference is that your registration.
Okay.
When you register in a council, FNBs and DMs can be registered. Our fellowships cannot be registered. These are for all branches.
Okay.
Even foreign fellowships cannot be. It's a feather in your cap where you are learned more into that.
Okay.
So in government or in teaching situation, that comes into role. In private, it doesn't. So once you have come, you decided you want to practice anesthesia or you want to do a super specialization. Afterwards, when you want to do only anesthesia, there is a lot of ways. One is freelancing, just like you addressed. Freelancing is like you visit multiple hospitals depending on case basis. There are cases happening, they call you, so and so patient, you go there, you give anesthesia, you finish the case, you go to the next hospital. The cases is not under your control. One day you might get lot of cases, one day you might not. So that is the issue. Secondly, your salary will be how many cases you can do.
Yeah.
Okay, and then there will be days where you are not doing any cases, so there is no guarantee. Those issues are there. Then second way is in government teaching colleges, where your academics will also continue. You will get to teach, you will upgrade your knowledge, and you will get a fixed salary. Third is in a corporate setup, where you are on a payroll. You get a payroll fixed salary.
Yeah.
Whatever you negotiate, it depends on your negotiating skills also, how you present yourself. And then once that fixed salary, it's fixed hours. You do the cases, and at the end of your hour, somebody or the other will relieve you.
Yeah.
There also time is money. The amount of time you do extra, you get paid extra. That's way. Then if you do super specialization in critical care or without super specialization in critical care, you can work in the ICU. Because anesthesiology is a part of training. You are trained in critical care, so you can handle ICU setups.
Yeah.
So you can either take ICU rounds, you can manage, you can go again freelancing just for intubation or line calls.
Yeah.
So that is also possible. Whichever interest you draw, or you can do both.
Yeah.
And third is that you can do only cardiac anesthesia. This is for CABG surgeries or valve replacement surgeries, which are under anesthesia. There are two types again in that, beating heart and on pump.
This is also fellowships, or these are like DMs?
Both options are available.
Both in this
See,
also.
it is the time. So fellowships are usually a short term.
Yeah.
So you can do it small as 6 months to 1 year. FNB is 2 years and DM is 3 years. In anesthesia field, it is better the faster you enter into the field, because the real learning will happen once you start. The more you go into academics, it will help you, no doubt, but it will take lot of years of you. It will take lot of your youth. So once we start into residency, once we come out, we are almost 30, 32. Once we finish DM and all that, you will be almost 33, 34. And you are starting afresh. It is easier to start under 30 than to start over 30.
Yeah, that's true. Yeah. So, but you will be needing a lot of contacts also. If you're freelancing and all, you will be needing contacts of surgeons and all. Is that?
No, just I told you that it's a community based. So you first meet your fellow anesthetist. You inquire how is the scenario around. Because I told you that anesthesiologists are always in a shortage.
Yeah.
And I'll explain to you why is the shortage. See, suppose we take example of Goa Medical College. There are 10 seats of anesthesia. Correct? Every year 10 anesthesiologists are coming up. How many surgical branches are there?
Surgical branches a lot, sir.
Gynec, surgery, general surgery, orthopedicians, plastic surgery, pediatric surgery,
CVTS is there.
CVTS, urology, neurosurgery. Everyone has their fixed number of residents passing. So for an idea, if there are 10 of anesthetists coming and 100 of surgeons coming up in that same batch. So this is 1/10 the ratio. And everyone require an anesthetist. So that's why this proportion is disproportionate. So that's why the shortage will always continue. The more the years will pass, the shortage. So you will, like other branches, there is a saturation. But in anesthesia, that saturation point will not less likely to happen.
So, but like there are rumors when students discuss, they think that there are saturation in metro cities and even in Goa when it comes to anesthesia. So, how much is that true?
As I have worked in Goa, I have worked in metro cities, Mumbai, I have worked in corporate, and I have worked in government setup, central government setup. The saturation word is more of a surgical branch thing than of an anesthesia thing. See, what happens is that, I don't know from where, but once you enter residency, there is a term called cutting. You people must be aware that cutting. But what is cutting? Cutting is surgical term. So that same thing people think for anesthesia. What is your cutting? You have got how many spinals, how many epidurals, how many GS, but that does not apply. Eventually, even if you do 2-3 cases, automatically your number will increase because you are doing it daily, at least so many times per day. Okay. So once you go out in the field, the same thing with your surgery colleagues or that. You think that there is a saturation, then you think there is a saturation. How is the saturation is that? What do you think is a part of saturation? There are no cases or there are no jobs. I told you in anesthesia, your jobs are always there. What you want to do, there might be a mismatch. See, like you want to do anesthesia cases, but you are getting opportunity in ICU. That mismatch might be possible.
Okay. So,
Okay.
yeah.
So cases you might get. Every day you see there are more and more hospitals coming up. So every hospital will require new anesthetists,
Yeah.
new surgeons. When there are new surgeons coming, new anesthetists will automatically come, new hospitals require.
Yeah.
So that is always there. Rumor is spreading because so many times what happens is that there is a trust building between the one senior surgeon and the senior anesthetist. So he's there, he's going with them. But finally he is also a human.
Yeah.
He will require a break someday or the other. That break happens. When break happens, you get a call, you will continue. That opportunity will be there. It's how you get that opportunity. What many of them do is they limit themselves in a certain part. See, Goa is, you should take Goa as a whole state. Goa is actually a small state, it's smaller than a metro.
Yeah.
So if you want to see like just in Bardes or just in Tiswadi or just in that part, then you might not find that. But if you take it as a whole, same way in Mumbai, I have to take whole Mumbai as my, or I have to take whole Goa as my opportunity. If I limit myself, then it becomes a...
Yeah. Okay, so you have to identify that area also where you get scope.
First, you have to identify what you want to do. You want to do anesthesia part, you want to do critical care part, or you want to do something different, or pain part or something.
So you're saying it's more of a mismatch.
Mismatch.
Okay.
So ideas mismatch. That's why people feel it is saturated.
And so roughly how much time it takes for a newly passed out to establish himself after, in that area as a renowned anesthetist? Renowned as in like to have a decent earning.
See, first of all, this most of them, they are called as behind the curtains. It is a reason for that. Very few of you will know the name of the anesthesiologist. You will know the name of the surgeon. So the word renowned again becomes a mismatch. Okay? You will earn a lot. You might earn more than the surgeon.
Yeah.
But you will be behind the curtain. That part is there.
Okay.
So there are super specialization like pain where you are in the forefront. You are on this side and on the other side. See, immediately after your residency, you can start working.
Yeah.
You can start taking cases. So you can be into ICU. You can manage critical care. When you are young, you will like to earn. You will roam. You will do maximum cases. You will walk into hospitals. You will travel. I said time is money. So you want money. So you will spend more and more time. I have seen youngsters spending almost 22 hours a day. Continuous. And then they enjoy because they get a thrill of working.
Yeah.
So that is the way. And then if you are working, you cannot continue 22 hours for a long stretch. It is like for a temporary part.
Yeah.
Then you do is you decide a fix hospitals. Once you start visiting, you know where hospitals to go, which surgeons to trust, which setup you like. Then you become choosy. You choose the setups. Then you join those. This entire time will almost take you around 1 year just to understand what is happening around, which are good setups, which are good. Because initially you will get few cases. Then as the case numbers increase, you will understand it better. Then you will start choosing where to go, where to do. And then you will start advising what is required and what is not required.
Yeah. So and so you were saying something? Yeah. What about going abroad, sir? How is that opportunity going abroad with anesthesia?
One of my friend had quoted this to me. If you go to US as an anesthesiologist, or if you are an anesthesiologist in US, in 1 year salary, you will drive a Ferrari.
The temptation.
The temptation of Ferrari can pull you there. But when I found out, I realized that in US you have to repeat your residency in anesthesia. So after anesthesia from India to go to US, it's become difficult. If you have done USMLE, if you have done previously, and if you are doing education over there, same way it is for engineering. It's like you do a BE here and you go for masters there, and after masters they give you a job in US. Same way is for our branches also, or any other branch. You have to repeat your residency. But there are few states where it is allowed, and if you get a sponsorship, loopholes are there. and then where you can practice only in that state. One I know of is Florida.
Okay.
So there are clinics and there are private hospitals where you can work, but you cannot practice rest of the country. So those issues are there. Second, UK and Gulf, they are also very lucrative. Okay, same way you get a very good car. So if you fancy cars, you will understand how you will figure out the numbers.
Yeah.
In America, it is like one of the top branches. Anesthesia goes into the highest pay scale. And there it is even different. Once you go abroad, each of this type of anesthesia is subdivided. So there is an anesthetist who will be only regional anesthetist. One will be only nerve blocks. One will be only for pediatric cases. One will be only for pain. So it will be a subdivision and they will not interchange. In India, we do everything. The same person is able and trained efficiently in all things. They are particularly trained only in one subtypes and they do full time that.
Yeah.
Okay, that is one thing. UK, if you want to go, you can. There are two options. One is the European Diploma, or you can do a FRC. For FRC, it takes a long time. It takes almost 7 years. Diploma is faster. Okay, you can do that. You can register. You get a license. You can work there. Again, you have to work under a senior consultant. They will see you how experienced it is. It is again protocol based. It's very different from what we are teaching is in India. If you have done a DNB, that is an advantage because you will be in a structured environment. So, and if you have done DNB from a corporate sector or corporate hospital, even better because it will be on the similar lines there. Same if you go to UAE, there is a different exam when you go in DAE. There is a DHA exam. So, if you clear that exam, you can get into there. One more thing is that most of these foreign countries like Gulf and all, most of the cases are done under general anesthesia. Or a lot of VIP patients, they are reluctant of poking or needles. So general anesthesia is more commonly practiced. Other option is the South Asian countries where also the salary is good. But which is almost similar which you can earn in India. It is almost in that gap. If you are working and if you have established yourself, established means as in you are working for 6 to 8 hours or more, not more than hours. If your cases are providing you sufficiently in money, your expenditure is less.
Yeah.
So definitely you'll earn in a bracket almost similar to those countries.
Okay.
So UK, if you can choose, if you're going, or Gulf countries you can choose.
Okay. And have you given any thought about DM, sir, in your career thing? Anytime you thought might do DM or I should do DM?
I got this thought when I was in the residency. So when we are in residency, we are taught by our seniors that after this you should do this. Like after MBBS you should do MD. After MD you should do DM.
Yeah.
But at one point I realized that this is a never-ending game. So if you get into MD, you get into DM, then after DM you get something, then you again go something. That is never enough. So if you want to progress academically, you can choose that one.
Yeah.
Because your time is goes.
Yeah.
You are total. I told you that you should start before 30.
Yeah.
If you cross 30 and then you are more into that, you finish by 37, 38.
Yeah.
And in Indian scenario, there is family and lot of things other involved. So you cannot spend that many years.
Yeah.
Which is my personal opinion.
Yeah.
And that's why I said that fellowship option was available. So I did fellowship.
Yeah.
And then I did multiple fellowships.
So that's what I meant, that sir said that it never ends, but ends up doing 4 more fellowships. It never ends, but 4 more. Okay. So we are going to talk about that also. Tell us about your fellowship experience, sir. You have done 4 in pain, in palliative care, in rheumatology, and in endoscopic spine. So tell us more about your fellowships and in bit detail about each of them.
First, I'll tell you about fellowship in pain.
Pain.
As I said before, I was not aware that there is a pain is a separate branch which exists. When I went to BARC, Baba Atomic Research Center Hospital, there it was a patient centric. So we used to see a patient, we used to examine thoroughly, and we used to work around it as a team. Because limited number of cases, we had time to assess and treat him in the optimal conditions. We had a case, patient was around 60-year-old teacher. He came with abdominal pain and vomiting. pain was such severe that she could not sit, she could not lie down. Sudden onset. We got admitted, done a USG, got a MRI done. There was CA pancreas with mets to liver everywhere. Surgeons took to OT, diagnostic scopy was done, found non-operable, advised palliative care. For the first time I heard the term palliative care. What we think of palliative is like something given at the time of death or something like that.
Yeah.
I am not aware. So then their team was called. The team came, they assessed, they decided that the first pain should be tackled. Pain causes depression. If you are in pain for a long time, you will get depressed.
Yeah.
That will alter your body physiology. So pain has to be tackled. So they took the patient, they did something called as celiac plexus neurolysis.
Yeah. I'm not going to pretend that I know what that is.
So, and after that, immediately the patient's pain was gone. I was surprised that what is this? Who are these people and what have they done?
Yeah.
So I said I'm always curious. So I went into finding what they have done.
Okay.
Why that and what is this branch? Immediately in that same week there was one more patient, and this one was around 28-year-old. He fell from a ladder and he had a fracture of the spine, L2 vertebral body compression fracture. And patient was again traumatized, cannot stand up. Imagine your spine fracture.
Yeah.
Ortho was saying, they said that you have to have bed rest for minimum 2 months. Pain was severe. Common painkillers, NSAIDs, even opioids were tried, but it was not controlling.
Yeah.
And he was a daily wage laborer, so he cannot lie bedridden for 2 months. How do you tackle this? So again we called pain and palliative team. Again the same group of people came. They examined, and they decided that we have to do something called as vertebroplasty and kyphoplasty. These are the terms I heard for the first time. They took him to the OT. They did kyphoplasty, which is like they put a needle inside, they inflate a balloon. Your whatever body is compressed fracture, so the balloon inflates it. Then through the same needle, cement is injected. That stabilizes it. Immediately after that, once the cement is hardened, pain is gone. After 2-3 days, patient discharged, resume back to duties. So these two incidents changed me.
Yeah.
So then I started reading what is this pain palliative, what are the options. And then I gave entrance. I said that very few centers were there was no awareness. So I found out which are the 2 centers working. Then I contacted them, asked them what is the procedure. One exam was happening. This was before my final exams. So I applied for it. I gave the entrance exam. And there were 2 seats available. My rank came was 4 or 5. So I thought that I am not getting. But I got an email that you are on wait list, and if somebody did not join, you might get. So after till that, my exams happened, my results came, everything happened, and almost I was finishing. That day I got a call that you are selected. Yeah. So I went to Kolkata, another new city, new metro. So I enjoyed it. This is part of the learning. So I spent a year in Kolkata doing my fellowship, where we did all kinds of cases. That's when I understood that what is pain. Pain is a perception. Everyone's perception is different. It is how we learn it. See, we have been told when we are growing up as a child, ki if we pick up something, it must be hot, it's burning you. So then we try to relate it that this is burning. It might be different for me, it might be different for you. For me, burning might be different with the sensation, because I cannot see it. It's just subjective, how I feel it. Same way you fall down and is it paining you? Is it paining you? That is the first question as a kid it's asked. So you don't know what pain is. So you slowly understand ki, oh, this is hurting me, so this must be pain. And over the time you grow thinking that that is pain, that is pain. So everyone's perception of pain is different. That is the first thing I got. Then I realized that pain is not very simple. It is a complex eternity which involves emotions also. So emotions can also manifest as pain, or emotional pain is also one part of it.
Okay.
Okay.
Mm.
There is not always a etiology
Mm.
causing it. That is another aspect to it.
Mm.
And there is something called as triggers. If there is a pain, we always believe that there is a pain happening because person is telling his pain is there. It might be a different version, or he might not be able to describe it to us. But whenever somebody says there is a pain, we take it that there is pain. Then we might classify it as genuine or somatic. But pain is taken for the point. After that, our duty is to search what is the trigger. Where is it originating from? In 80 to 90% of the cases, it's very difficult to find what the trigger is.
Yeah.
And all the medicines they are already taken. Usually it is the NSAIDs or WHO ladder is followed. There is a WHO ladder for pain which is followed. So usually this kind of patients, they come with a huge bunch of file. They have roamed many doctors and they're still struggling. So then we categorize it as chronic pain. So any pain lasting more than 4 weeks is chronic pain. Less than 4 weeks is acute pain.
Okay.
Okay. So then we went into this. I found out what are the triggers, what are the treatment options happen. So whether it is MSK, it is a bony pain, it is a nerve related pain, it is a somatic pain, or it is any other thing, is a cancer pain, or it is because of any other condition which is affecting. So that was our main job into finding it. And then treatment comes afterwards once you found out. So it was a very interesting part because I liked it. I like to read. I like to research. It was like almost a detective thing. You are finding something which no one around you has been able to sort out.
Yeah.
And the best part is once you give a patient relief, even if you are able to give 80% relief, patient is happy.
Yeah.
Because he's struggling from it for a long
time, right?
So always if it's not 100% relief is the target, 80 to 90% is the target. And that is possible.
Okay.
Okay. So that's how I did it. Then I went into after pain. I understood that there are other parts to it, like cancer pain. There is a rheumatological MSK pain. So for cancer pain, I came to know that there is this palliative thing, which is you have to learn. So Indian Association of Palliative Care, they offer a course called CEPC.
Okay.
It can be taken after MBBS also, and it can be taken post MD also. Minimum criteria is MBBS. So only the duration changes. How many times you have to take. So I did that course. I did the training.
Yeah.
I did the examination. I cleared it. And then I got an understanding on what are the palliative aspects which you can treat.
Yeah.
But still I was missing on the rheumatology part. So I decided to do a training under that.
Yeah.
Once you have done rheumatology trainings, it becomes easier to practice. Because pain is a wholesome, when you go for search of those triggers, sometimes it is a rheumatological conditions.
Yeah.
So if you have found a trigger, but if you are not able to treat, it's difficult.
Yeah.
So to be able to treat, I had to learn it in more detail.
Yeah.
After that, I did it. I started practicing. I started learning it. And for 2 years to 3 years, I practiced pain with anesthesia.
Okay.
During that time, I learned that whatever I was able to give is 80 to 90% relief. But after a certain time, it comes back because the nerves regenerate, the medicines gets absorbed in the body. So the things keep on coming. So then I went in search what is the way where you can make it curative or which gives very good results at a faster pace. The patient is also happy and I can decrease the medications. So that's when I found out that if you can remove the cause, like in spinal or in spinal pain, there are mostly the disc bulges or canal stenosis which is happening. Either there is something called slip disc which you must have heard, or you must have heard of sciatica. So there is a nerve compression happening. Either it is a mechanical, anatomical, something is pushing or something is compressing. And if I am able to remove it or if I am able to decompress it, there is nothing like it. Now is free, the pain goes. So I went into search for it. I came to know this surgeons, they open it and they operate it. But the recovery time is very vast. So I said that I want to do something where the recovery time is less. It is minimally invasive because that is my forte. And it should be done under local anesthesia as a daycare procedure. So that's when I found out that endoscopy is done in this way. Then I found out that very few of the pain centers are doing it, but it is part of the DM curriculum. So
Okay.
this is already included in anesthesia part.
Okay.
Very few people are not aware that anesthetist or a pain physician can do, not an anesthetist, can do endoscopic spine procedures.
Okay.
Okay.
Yeah.
So
Okay.
then I went into learning of that. Now we started it, and when we do it under local anesthesia. Patient is fully awake. Advantage being the patient can tell us if we are close to the nerve. Usually, in what happens in this open surgeries, patient is under complete anesthesia. So only way you can come to know is after the case is done. Even if you do a neuro monitoring inside, still it will let you know once the damage is already done. But here the patient itself is the monitor. Patient will tell you if there is anything close to the nerve. So that is a huge advantage.
Yeah.
And it's a very quick procedure. And you can walk on the same day immediately after. Patient gives almost 90 to 100% relief. And patient has to do lifestyle modifications. Once the modification is done, patient is very good to walk out.
Okay.
So those were the advantages. So that's how I stepped from one step to another center dependent.
Yeah.
But I did all this in a lesser time frame.
Okay.
If I had gone for the DM, I would have done this, but it will be 3 years plus maybe bond. Now DM also has bond.
Okay.
So counted as 4 years. 4 years of that, 4 years of residency, 8 years goes here. Plus 1-2 years of preparation, 10 years into this. Correct.
Yeah.
So you finish your MBBS around 25. 10 years is 35.
How severe is this cancer pain and even rheumatology associated pain? So how does the patient come and how severe that is?
See, usually cancer pain is almost like terminal or a palliative care management.
Yeah.
Your patient is already been diagnosed. Usually interventions or surgeries, if possible, are already done. They already taken chemo radio cycles, which are also painful. Chemo radio cycles, if you know, are very painful to the patients. After that, even that pain is not subsiding. Then we have to do something called as neurolysis of the nerves. The nerves which supply that part is totally burnt with medications such as alcohol or phenol. We destroy it so that the conduction does not happen.
Yeah.
So patient, the pain is considerably significantly reduced. There are other modalities such as interventions. We put continuous epidural catheters, continuous neurolytic blocks, which help the patient for the pain severity to reduce.
Okay.
Secondly, there are options such as patches which are available, which are stickers which can be put, no need of oral medication.
Fentanyl patch I heard about.
Fentanyl, buprenorphine patches.
Okay.
So these are medicated patches available in various doses, which is again. Then advanced, most ultimate is morphine. So morphine has to be taken by the clock, by the time, by the mouth. There's a protocol for it, and there is nothing more powerful than morphine with us right now. So only the other thing is the interventions where we destroy the nerve. Nothing in between. So when the patient is at palliative stage, when the pain is more than the life, patient does not want to live because of the pain. You just relieve him of the pain, and patient is happy.
Yeah.
I'll give you an example. 2 examples actually. One was a female, 38-year-old. She had CA breast, and it was a relapse case. First she had operated, now she had a relapse. She had already gone chemo, radio, young female. She had children, husband, and they could not see her struggling in that pain. She was already on max out morphine, but pain was not subsiding. So it was referred to me by a oncosurgeon. In CA breast, usually what happens is the breast and the entire hand has lymphadenoma.
Yeah.
Because of the lymph node dissection and all. So it's very difficult for that nerve to be found or anything to be found. So we had to do is the entire arm was blocked. We put a catheter inside and kept a catheter with medications continuous. See, this is not usually ideal setup, but we have to tailor make plans for individual cases. Advantage being ki the medicine will last for 7 days. There are automatic pumps which go with the catheter. Catheter is placed permanently. Medications go. The husband is to come every 7 days, refill it, and they go. After 4 months, the patient passed away. Okay. And after some few days, the husband came to return the pumps to us. I said, sorry for your loss. No, he came and told me thank you. I was surprised. Why? He said, you made her comfortable in her last. We saw her suffer. As the pain was taken care of, the patient was happy. She was smiling till the last. So when dealing with cancer pain, there are a lot of emotions involved. It's not more always about money. It is more of emotional connect, and you automatically, because you are seeing the patient for them, you know eventually what is going to happen. Even the patients are aware of that. So what we give is the stress-free, pain-free, and dignity-full last wish. That is more on the cancer pain part. Even recently, I had a patient who had a CA pancreas, and the same block which I had seen for the first time, I had done on a patient, and the patient got discharged the next day.
Nice.
So the life travels in a circle. You end up doing that, and you feel a very good satisfaction from doing it. Secondly, the type of rheumatology cases you said. So rheumatology is like an autoimmune condition. It is a vast array. We know only about this rheumatoid arthritis.
Yeah.
But arthritis itself can be classified into more another 40-50 types.
Okay.
Okay. There are different, there are post-viral, there are gouty. Each one is sub-classified. So it is a different field in altogether. There are specialized rheumatologists for this. But what happens is these are very limited in number. Patients, they roam around finding for that. It depends where you go. If you go to a orthopedician, he will treat you differently. If you go to a surgeon, he will treat you differently. If you go to a medicine, he will treat you differently. So once you identify what it is and you give them relief, that's how it works. But in this autoimmune condition, the relapse tend to happen. So you have to make a level, means you have to keep regular follow-ups.
Yeah.
So that the level is maintained and the relapse are less often. That is how rheumatology usually works.
Yeah.
Even there are these other pathies tried for rheumatology, you must have heard.
Yeah.
But it is almost like similar results. Whatever we are doing, whatever they are doing, some people combine both and they try. But finally, if the pain is led, whatever works is best. Okay. Second, there are acute conditions which happen in rheumatology. Suddenly there is a flare up and all the joints get inflamed. So ultimate aim is to get those swellings to down. Then you can do interventions where there is a degeneration already happened to prevent it. So those are the ways we can tackle in rheumatology as well as in cancer pain.
Okay, sir. And along the same line, I want you to explain now. Pain medicine is something which we have not come across as often. Like I also have seen very few pain physicians. So people, the doctors who are dealing with pain related patients, the orthopedician or other doctors, when do they decide that the patient should be referred to a pain physician? And secondly, when the patient decides themselves that right now I have that kind of pain and I should go to a pain physician. So these two I want you to tell us.
See, usually anything more than 4 weeks, any pain which is lasting more than 4 weeks, which is not subsiding by your medications, which are normal painkillers are taking, or it is relapsing again and again. Okay, or it is causing you, making you stay away from your daily activities. That's when you see a pain physician. The most common conditions which we deal with are back pain, chronic back pain, neck pains, headaches. Common terminologies used are sciatica, slip disc, spondylosis, spondylolisthesis. These are the terms which we have heard. Frozen shoulders, migraines. Now, according to the latest research, 80% of the headaches are not migraines which are classified earlier.
Okay.
So they are classified into subtypes. Many of the time they are cervicogenic headaches. They are occipital neuralgias. They are triggering it. Sometimes as simple as jaw pain or tooth pain is triggering headaches, which has been treated as migraine for generations. So once we are able to find out what is the trigger point, it disappears. The cycle of relapse is stopped and patients get lot of relief.
Yeah.
So usually what happens is when we get referred from orthopedician, so that when there is no surgical interventions involved. So I'll give you an example. If there is a knee pain, there are 2-3 causes which are important, very more commonly. One is osteoarthritis, where the knee is totally worn out. There are grades to it. Second is a ligament or injury. Third is a bursitis or inflammation or infection which is happening around it. So whenever there is osteoarthritis, if it's a grade 3, grade 4, they advise you surgery. If it's less than that, you can make a conservative measures, or we can do a regenerative measures. That is when the role of pain physician comes. Secondly, same, if it's a ligament injury, if it's a complete tear, then there's a surgical intervention. If it is a partial tear, it is a pain physician intervention. Same with frozen shoulder. If there is a tear, partial, complete. If it's complete, surgery. If it's a partial, we can prevent it, we can heal it. Frozen shoulder, it is more of adhesive capsulitis. So there is an adhesion which is stuck. So we can separate it, minimally invasive. That is done. Spine, there's a lot of array. Almost, if you know at least few people around you who have back pain. Most of the people are more than 35 have back pain. But when you require treatment, when it is bothering you, when it is making your movements difficult, when simple painkillers, massages is not helping you, that is where the interventions come in. And it is treatable. Once you visit a pain physician, he can find what trigger is causing it, and he can suggest and make a plan which is specially made for your treatment. It is a systematic approach. It is an algorithmic protocol-based approach. But once at the end of it, you will get results. You himself will come to know what difference it is making. And when the patient comes, most of the patients which come to my OPD, they have come with such big files. They are suffering from 15 years, 20 years. They
already tried everything.
They have tried everything. They have tried chiropractors. They have tried massages. They have tried all kinds of pathies. And then they come as a last resort. By this time, there is a part of depression also affecting them. It affects their family life. It affects them emotionally. It exhausts them. So we deal it as completely. We try to separate all their factors. We treat him as a whole. And whenever you visit a pain physician, either it's me or any pain physician, first thing he will be very interested is to know your entire history. He will give you time. He'll listen to you. He'll listen to your complaints. That is what misses in other fields right now. The time you give to a patient in OPDs or in a government service is very busy. If you are seeing a 100 patient OPD, or if you are seeing even a 50 patient OPD, you finish it in 2 hours. Maximum time you can give a patient is 2 to 3 minutes or 4 minutes. But if you want to treat a patient of pain, it will take minimum 15 to 20 minutes just to understand the case. So first understanding, and then starts the finding, and then starts the treatment.
And so what are some of the procedures you do on daily basis?
There are minimally invasive pain procedures which are done for treatment of pain. Minimally invasive resin, we just do it under local anesthesia. We just numb that part. We use a very small needle, or we use a small probes. We use advanced machinery like ultrasonography or CM or X-ray or cath labs, and we reach the target, which is the trigger point. After reaching the trigger point, we give medications which help relieve the swelling around it, which relieve the pain, and you feel better. Most commonly which we do is in back pain, which we do facetal injections. We do something called as TFESIs. TFESI is transforaminal epidural injection. There are medications, cocktail of 2-3 medications combined, which are injected over there. Then third is something called as regenerative medicine. In regenerative medicine, what we do is we take your own blood. You know that platelets help in healing. So we hyperconcentrate your platelets. We separate it, we centrifuge it, we separate the higher concentration of platelets, and we inject it in the local area where it is required. Wherever there is a ligament injury, wherever there is a degeneration happening, we inject it there, and so it helps in healing it. Okay, so this has to be done in cycles, at least 2 to 3 sessions at around 10 to 15 days apart. After that, at the end of the 3 sessions, which is usually fully recovered, or at least 90% recovery is there. And most commonly procedures are this we are done for sciatica, For sciatica, we do nerve blocks, injections. There are some ozone injections, which will be specifically made depending on your trigger, on your pathology, and cater made for your physiology. Secondly, frozen shoulders, spondylosis, migraines, osteoarthritis. These are the most common patients which come to us in the OPD. Of that, knee pain and back pain are the maximum.
Common, okay. And sir, you have worked in multiple hospitals, corporate setups, and you, as you had previously said, that you really enjoy working there. So, can you tell us about that journey of yours and how it is different from working in government setup versus corporate setup?
I have worked in government, I have worked in central government, I have worked in corporate, I have worked in small hospitals, I have worked in big hospitals. So when you work in government, it's more of a less resourceful setup. So you try to figure out on yourself how to optimize it, or whatever, you make best use of whatever things which is available to you. There's a term in Hindi for this, is called jugaad. So you learn more of jugaad in government setup. Okay. Technology might not be that advanced, but you know to how to work in a limited technology setup. So that makes you much more confident to handle to work in a less resourceful setups. Government has the advantage, there is huge workload. So the more you work, the more you practice, the more you learn. That is what we were told. And that is how we have learned. So if I tell you a normal day in GMC, in a night, we used to do 30 cases. 30 in a night. Just one night on an on-call day. That's a huge number. So that is all entirely done by you. So that is the advantage. You learn a lot immediately within your first 6 months or 1 year of residency. So by second year, you just polish it. By third year, you polish it and you learn it, read it finally. So that is one advantage. Government gives you a lot of work. Gives you a lot of patience. You get your variety. But you have to work fast, and their time becomes less. When you work in a central government, some amount of resources are better than the government. Secondly, the cases loads are slightly different, like more of a polished cases. You get very variety of cases. You can make a plan, you work with a team. There is time available for you to make decisions. There is enough technology and there is time for them to teach you. In government, the time factor becomes a problem where any person can come and teach you because you are very busy. In corporate setting, there is the time as an advantage where somebody can teach you or you have a time to learn from somebody. Once you go into corporate is a different world together. It's nothing like government, it's not like central government. What is different is that it is more of algorithms, protocols. There are protocols in place for everything. It is more patient-centric. Patient is the God. Patient is the VIP. Patient is the most important person. And he is trusting you. So you are free to do whatever it takes so that he gets the best result. Here, money is not the issue. In government, money is a factor. Central government, again, money comes a factor. But in a private or a corporate setup, patient himself is paying for either by insurance or by cash. But he is paying and he wants the best outcome out of it. So you learn to how to deal with it, how to deal with the relatives of such patients. The types of cases are different. You might get VVIP patients with you. You might handle very film stars. You might get politicians. You might get very important persons and you might be dealing directly with them. So this is a different experience you get. Plus all the technology which you have read or which you have not even heard of is available there. So you get a first-hand exposure to that. What we used to say is that like there is a 5 years gap in everything. 5 years to 10 years. Abroad, USA is 10 years or 5 years ahead of us. Indian corporate sectors are slightly behind, maybe 5-7 years, 5 years to be like that. Government setups are like slightly behind that way. So if you understand what I'm saying, is like government setups are still behind when you compare to the most advanced nations. but the corporates gives you a feel how the advanced nations are working. So that makes you more confident, that makes you prepared. And if you have gone through a government into a corporate, you get the idea of both worlds. So that is a good way of learning.
Yeah.
It makes you more confident to handle any kind of cases. Your name is known. So like in government and in central government, you are coming or you getting a renown is very difficult.
Yeah.
But when you are in this corporate, you itself become a brand, or you become your name is out there, because they display your name on the board. Your name is on the main board of the hospital as an anesthetist. You are now along with the surgeon name. Even on the outside the OT, your name is displayed. So they are constantly reading. You have at least 4 or 5 visits with the patient, pre-op, intra-op, post-op, even after that. So there is a rapport which builds with the patient. They know you. And so many times when they come for any other case, they recommend you. So that things your name spreads. So that advantage is there, that exposure is there. And in corporate, time is money, because you are getting paid, you enjoy it even more.
Yeah.
So pay is way, there is a huge difference.
It's a motivation sort of thing.
Yeah, it's a motivation. There's a huge difference between the pay in government, central government, and a corporate. And that gap is just expanding.
Okay. And sir, as you were talking about the technology part and all that, so what do you think are going to be the evolving trends in next 10 years when it comes to technology and pain medicine and anesthesia?
See, I'm a fan of technology.
Yeah.
So when I joined anesthesia, I was amazed by the amount of technology we are using. So there's a machine which helps you in bleeding. It's a ventilator.
Okay.
But there is one more machine which is called as anesthesia workstation.
Okay.
Which is a ventilator, plus it is a delivery system for anesthesia medicines.
Oh.
There is one more myth, ki anesthesia is just injection. Anesthesia is not only injection. It involves a lot of technology part.
Yeah.
The machine is connected during general anesthesia. It takes care of your breathing. It maintains you into a deeper plane. It basically pauses your thing so that the surgeon can operate. It is a controlled environment. Monitors are attached to it. Your continuous monitoring is done. Now with the advancement of AI, this monitoring and the vapor delivery can be AI enabled.
Yeah.
So it can decide how much is required, it can give you a precise calculation. It can help you in the monitoring, it can sound you with the better alarms, it can anticipate better. But finally the call has to be taken by a human.
Yeah.
So the anesthesiologist's role will always remain in that way. One more technology which we use in pain medicine is called as spinal cord stimulator.
Okay.
So it is like a strip of electrodes which we insert in the epidural space in the spinal, near the spinal cord. So what it happens is that whenever there is a severe pain, neuralgia, or there is paralysis or something like that, or those kind of conditions, we put it and it gives electric impulses. These impulses override the pain impulses. So it takes care of it. And now with the AI enabled, it can sense better when to deliver. And one more technology which I am very eager and excited to know is Neuralink. Have you heard of Neuralink?
We heard in movies and all that, sir. Like mostly I've come across during games and all that. Like you play it, put that vision thing, it is connected to your brain, then you feel like you are playing it.
The one you're talking of is called as VR, visual reality. So visual reality is also used. So visual reality is you put a goggle and a scene is shown against you and it makes you feel. So this helps very good in calming you. Anxiety. Even this is tried. When you're undergoing operation, you can put a VR goggles and you enjoy a nice scene, you watch a movie, you can do anything. The surgery is going on, you are much more relaxed. Hemodynamically, you are much more stable. Okay. All those catecholamines and all those oxides or radicals are less released when you are less of stress. Neuralink is different. So I'll put a light on Neuralink. You know of Elon Musk. One of his companies is Neuralink. So what it is doing, he has developed a chip. By surgery, it is implanted in the brain. Okay. And it scans, analyzes all the synapses which are happening. It reads it, it analyzes it, and it is able to transmit the signals. So he has made it for cord paralysis, paralytic patient, so that it encourages them to move. And already it has reached in such advanced stage, almost switched to stage 3, stage 4, I guess, of clinical trials where it is going to be started on humans, or I guess it's already started on humans.
I have heard that, I think, in some reels and all, I had seen some plesia patients were like standing with that suit and all that.
So if it comes, it will be a game changer.
Yeah.
So it will be a innovation of next level.
Okay, sir. Okay.
And already in last 10 years, anesthesia has evolved in technology. Like machines have improved. First it was boils, there was gas. You must have heard of ether. They used to drop that ether. And if the ether is low, patient needs to not wake up. If the bottle drops, the entire OT team is to fall asleep. These things have happened. Plus ether was explosive. So you were working with a bomb almost. So now all that is gone.
Yeah.
All these drugs or whatever, all machineries which we read in textbooks are now in the museums.
Yeah.
So this is what, when we enter anesthesia, I was searching for ether. That was not there. Then I heard for boils. It was not there. But once you start practicing, and if you go in rural setup, you'll still find this thing. So that's why that is important.
Okay.
Okay. And then after that technology, that USG, ultrasound. So with ultrasound, a lot of things have become safer. We can see the nerves when we go and block. So there is less chances of nerve injuries.
Okay.
So it is very fantastic. And if you enjoy video games, then anesthesia is for you. It is like, but here you have to be very responsible. But there are a lot of machinery and things which you use. Okay. And you get enjoy using it.
The thrill of it.
The thrill of it.
Okay. Okay, sir. So now we have covered most of the major things. Now we are coming to a rapid fire round. One OT habit you never compromise on.
Oh, this is a good one.
Yeah.
See, it is airway readiness.
Yeah.
And patient safety.
Okay. Okay.
I always check that the airway, if any requirement is there, airway readiness interventions are possible and patient is properly secured.
Okay. Okay. Most challenging surgery you have ever handled?
I think I have told, but any cases or any emergency cases with an unstable patient is a challenging surgery.
Yeah. Okay. One thing the public should appreciate more about anesthesiologist.
See, he is the one who is taking care of you pre-surgery, intra-surgery and post-surgery.
Yeah. Okay.
He is the one between your life and anything deteriorate.
Okay. So during residency, you preferred coffee or sleep, whatever time you got?
Obviously coffee.
I thought you said sleep, sir. Coffee, okay. Okay. One branch myth you want to destroy forever?
Anesthesia is only giving injection.
Okay,
see, anesthesia is not only injection, it is a huge array.
Yeah, we saw how huge it is, sir. Okay. Okay. Now we have covered a lot of ground when it comes to anesthesia, pain medicine, various fellowships, and you being the first generation doctor, and to do all this is inspirational in itself. So I want you to give a final piece of advice to young doctors who are going to take anesthesia as a PG branch and looking to do, even the residents who are doing anesthesia, and they might think about various fellowships you have told. So I want you to give them some advice.
The most important advice for a future PG, not only anesthesia or anything, any branch for say, is that one, you should be responsible. Second, you should be humble. And you should never forget that the patient trusts you with his life.
Yeah. You have done a lot of things as a first generation doctor. So does it make sense to take anesthesia as a first generation doctor? Is it always like how you have done, or there can be challenges?
See, there are always ups and downs and challenges are present. But as a first generation doctor, if you take anesthesia, you have a lot of opportunities. You can start immediately. After your residency, you can start working immediately. There will be a steady flow of monetary benefits also. So you are settled very quickly. Your expertise develop very quickly. The amount of learning curve is lesser than other surgical branches. So you can take anesthesia. You don't always require a godfather or anything, but it is better to have mentors. One of my seniors very early in my residency had told me that you should search 5 mentors in the field and then you try to match them. So I always went in search of those 5 mentors for me. And till now I have been able to get 4 of those mentors. The search for the 5th one is still on.
You are the 5th one, so for yours.
Oh my God. So this medicine is a journey and we are learning continuously. So it will continue. So in life, as we progress, the 5th mentor, maybe 6, 7 might find.
Yeah.
But mentors are very important. So they help you in shaping you how you are. So you try to be like them.
Yeah.
So choosing the right mentor becomes very important. As a first generation, it's even more important.
So yeah.
So once you choose the right mentor, you follow and you know how your future is gonna be.
Yeah. So with this episode, I think you have become the first mentor for a lot of people now.
Hopefully, yes.
Yes.
And I can help your audience.
Yeah.
And more than me, you are a mentor.
I just try to get the good people, sir, and I also learn while interviewing. So it's a good experience for me also.
And as an interviewer, you have to ask the right questions, and which you are doing that wonderfully.
Thank you so much, sir. If you're getting anesthesia in periphery or you should take a drop, which is better?
That's another interesting question. So if you take anesthesia in a periphery means a rural college. A rural college, if you are practicing in which part of India, that depends. And finally, whether you want to take a drop or it is number of attempt of it, it's totally your decision. Okay. Anesthesia, you can learn even in periphery, even you can learn in DNB, you can learn in a metro. Things won't change much. Only the resources will be different. So even if you get it, you take it, you complete it, and then you can go and do more of it. So you can do, obviously there are fellowships like I have done. So you can go in search of that. And by advantage of fellowships is you can jump also. If you don't like it, you can just go into others. When you are doing a DM or a MD, it becomes very difficult to leave it and go. But with fellowships, you have that option always available with you. There is no bonds for fellowships. So you can see from one center, if you are not happy with it or if some things are not working right for you, you can switch. You can do fellowships abroad. Or if you want to, if you think that you are in a rural, you didn't get this kind of exposure, then again you can go and find out of that setup. So there is always a way. If it's up to you how you want to proceed. So if you want to proceed, if you don't want to drop, my advice always is to continue. If you're getting it, take it, because the earlier you go into the field, the better it is. The more time you spend outside, you will be more of thinking that this would have been better, this is better. So once you start working and then you perfect it.
Yeah. Even I used to say that, sir, that PG is more about getting that direction. The faster you get, better it is for you. Okay.
And once you get it, make it the right one.
Yeah, there's no looking back once you take the decision. Okay. So I think we have covered a lot about anesthesia as a branch. What are the career prospects, the earning potential. Then there are different fellowships, pain medicine that we have not come across as often. So that has been explained in very much detail. And I think this is one episode that has been a complete package of emotional guidance, professional guidance, financial guidance. So we are very thankful for that to Kaushal sir, that he came and gave us his hours, which are like very important. So we are very thankful for that, and I hope that this episode is very helpful for you all, and sir becomes the first guide for you all. So thank you so much, sir, for your time.
I appreciate and thank you very much for having me.
Yes, sir. Thank you, sir.